Guys, continuing with the cardiovascular system pathology, the lecture today is the left ventricular failure or left heart failure. I think probably the most important lecture, the most important topic in the whole the cardiovascular pathology and in the whole pathology. I would even go to that much. I think inflammation and some other things are also very important. Anyways, why this is important, look at the statistics here and you would find out. So look, in the US, about 5 million patients suffer from cardiac failure. Out of those, about 1 million patients yearly are hospitalized. 300,000 patients die of the cardiac failure causes, and majority of the cardiac failures you would see down here are because of systolic failure of the left ventricular heart. That is the topic today. Majority of the dysfunction or majority of the heart failure types are systolic. We'll talk about the types today. The minority is of course diastolic type. Then the diastolic heart failure is most common in elderly and in women. Common causes for the left heart failure, so right now you should know this: ischemic heart diseases, hypertension, hypercholesterolemia. These are the primary major causes. Some congenital defects like septal defect, valvular regurg and valvular stenosis are also participant, but really coronary heart diseases, ischemic heart diseases are the most important. And you know why I'm saying that is coronary heart disease can be preventable. Yes, it progresses with the age as well, but high cholesterol levels are important. Controlling the hypertension is important. Controlling diabetes mellitus is important. So these are all preventable things. A healthy lifestyle is important for this. And finally, the high output failure, which is a separate lecture, is a minor kind of a problem. So with this, let's start. The way we'll study is, first of all, we'll try to understand the definition of the left heart failure. Then we'll do the pathogenesis, what causes the left heart failure. We'll do the findings, the lab findings that you would see. You'll see then the clinical signs and symptoms that you would observe. And of course, as you saw from the stats, probably majority of your patients are going to have some sort of majority of the patients with the cardiac problems would have this problem. So make sure that you understand it. The things that we need to understand now is, what is the heart failure? Number two, what is the forward versus backward failure? Number three, what is systolic versus diastolic failure? Let's get those out of the way and then we'll talk about the left heart specifically. Look, forward failure versus the backward failure. Forward failure is that the heart, this is the heart here, is unable to pump enough that the viscera and the tissues can get the blood supply, adequate blood supply. That is a forward failure. A backward failure is that heart, when it is not able to pump enough out, that causes backward pooling of the blood. The blood cannot come in easily as well, and that causes the blood to start accumulating in tissues behind the heart, and that causes congestion, and that is a backward failure. Then is systolic failure versus diastolic failure. So look, heart cycle has two phases. Of course, filling phase or diastole, in which heart relaxes, fills with the blood, and then at the diastole time it ejects it. Systolic dysfunction or systolic heart failure will mean that when the ventricle contracts, when it squeezes, it cannot eject the right amount of the blood volume that it should eject. That is a systolic failure. Systolic function is not working. There is diastolic failure as well, where diastolic function is not happening correctly. And what is diastolic function? What is the function of diastole? Diastole's function is to relax the heart during the diastole and allow the heart to be filled with the blood to be pumped. So if the heart is not relaxed correctly, then it will not fill enough with the blood that can be pumped. So that is diastolic failure. Systolic versus diastolic is something that you have to understand not only for the left and right heart, but also from cardiac output and ejection fraction point of view. So let's look at that mathematically as well, because this is something that is going to appear in your exams plus in your lab findings. So look, let's make a normal ventricle here. So this is a ventricle, this is normal ventricle, and let's say the way this ventricle is working is that blood comes in to the ventricle, it fills up to a particular amount, so that is the end diastolic volume, that is the amount of blood that is present in the ventricle at the end of the diastole. This is the amount of blood on which the heart is going to work to eject it. Then this ventricle is going to eject that blood. It is going to squeeze and go in a systole. So let's say the ventricle now squeezes. It has squeezed to allow that blood or part of that blood to be ejected in the aorta. Aorta, we're talking the left side. So let's say this is that blood that is just ejected. And of course, there is some blood that would still be left in the ventricle after the ejection. That is the end systolic volume. Now, what is the stroke volume? Stroke volume equals end diastolic volume, that is the original volume we started with, minus end systolic volume, that is the volume we are left with, and if you subtract them, so let's say here it was 120 milliliters. What we got out was, let's say, 60 milliliters. Sorry, what we are left with after the ejection happened is 60 milliliter. So how much blood went out? 120 minus 60 equals 60 milliliters is left. Now, what is ejection fraction? So look, I'm not doing a big lecture here with these, because we have done separate complete lectures discussing the stroke volumes and diastolic volumes, systolic volume and ejection fraction. I'm just using enough to make a point about systolic and diastolic dysfunction. So now let's say ejection fraction of this heart. Ejection fraction is the percentage of the blood that is ejected from the heart when it went in a systole. So how do we know that percentage? What we need to know is what is the total blood that was present when the heart started squeezing, and the amount of blood that left. If you divide that by the total blood, that would give you the ejection fraction. So that means stroke volume divided by end diastolic volume. Stroke volume divided by end diastolic volume is going to give us ejection fraction. How do we get the stroke volume? We have end diastolic volume minus end systolic volume. So in this particular case, we put 60 milliliters divided by 120 milliliters, and that comes to be 50%. Of course, I made it easy for myself to do quick math here on the board. Normally, the heart's ejection fraction, a healthy person's heart ejection fraction, is above 55%. In athletes and in people who do exercises, ejection fraction can go up normally when they are exercising up to 80 to 90%. So that is the ejection fraction. What is the definition of ejection fraction? Percentage of the blood ejected from the heart in one stroke. Out of it's the percentage. Okay. Now let's look at the systolic dysfunction. Systolic dysfunction means when the heart was squeezing, it was not able to eject properly. So of course the cardiac output is reduced. That is why we have a problem. Heart is failing, it cannot nourish these tissues. So let's see what systolic dysfunction will mean. Here we have a heart. This heart has some blood. Let's use 120 milliliters, same as the normal. So there is 120 milliliters blood present in it. Heart undergoes the systole and heart is damaged. This heart is damaged for some reason. For example, there is ischemic heart disease, or there is ischemia of the heart, ischemic damage, or there is infarctive damage. So this heart is damaged. So the amount of blood it ejected Now, instead of, let's say in this normal heart, 60 milliliter was left, this time what is left is, let's say, 80 milliliters and systolic volume. So how much is, what is the stroke volume then? You subtract 120 and 80, 80 from 120, 40 milliliters. So 40 milliliters is ejected. Now the 40 milliliter ejection out of 120, so what do is you get the ejection fraction by dividing 40 and 120. So that is 1/3, 33%. So is that a good ejection fraction? No. Is that good output? You may, just looking at the output, you might say, yeah, it sounds fine. But it really depends what percentage of the blood went out. That tells you what was the blood to work on, and did heart performed well. So no, this heart did not perform well. This was 33% ejection. This is called systolic dysfunction. Now diastolic dysfunction means systole is happening okay, but there is some problem with the diastolic function. So let's look at that. Let's say the heart which has diastolic dysfunction, that heart is a little larger, dilated. Now in this heart, the blood that is present is 240 milliliter. I'm exaggerating again for my own need. So let's say the blood that is present in there is, actually let's make it 200 milliliters. How much came out? 60 over there. Let's make it 140 milliliter just to make it easy for me. There's 140 milliliters. The blood, when the heart now went into the systole, of course there was a lots of blood, so it could not eject that all. The end systolic volume now is, let's say, 90 milliliters. So that is the blood that is left here. So how much of the blood is ejected? You subtract them. 140, 90 minus 140, 50 milliliters of the blood is ejected. So 50 milliliter is ejected. Now what you do is you take the ejection fraction, that is 50 divided by 140, and that gives you 1/3 and 1/4. Normally what would happen is, let me correct it the way it should be for this one. So instead of 90, let's say 60. That means about 80 ml went out. So if you do the 80 ml and here 80 ml, it is even more than 50%. The point is this: in the diastolic dysfunction, there may be more blood present and relatively good amount of blood that is getting out, or there may be less blood present. For example, in hypertrophied heart, which is thick, and let's make that one here, this is a thick heart. It has a small lumen, the cavity is small, so the amount of blood in here is less. So let's say it can only contain 80 ml because the cavity size is small, because the ventricle has become hypertrophied. Now when it contracts, let's say it ejects, it is left with, the end systolic volume is 40 ml. How much is ejected? 50%. Now here the cardiac output is below normal and the ejection fraction is normal. This heart is suffering, this heart is failing with the normal or above normal ejection fraction. So that is what I want you to take away, that in the diastolic dysfunction, ejection fraction is normal or above normal. However, cardiac output is low because there is not enough blood in the heart, or there is so much blood that heart cannot pump out. Actually, you know what? This one is an example of systolic dysfunction. Systolic. This is diastolic. So I don't want you to create an incorrect concept here. Systolic, when heart cannot eject properly, that is a systolic dysfunction. When heart ejects properly but there is not enough blood to eject, that is a diastolic dysfunction, and this is the example of the diastolic dysfunction. Okay, so now we understand the difference between systolic and diastolic dysfunction. Let us now start with the left ventricular failure. So first of all, what is the pathogenesis of the left ventricular failure? Reduced contractility. We're talking about the systolic dysfunction first. Reduced contractility. Okay, so let's start with the systolic dysfunction. So let's say here is our heart. This is the left atrium. This is left ventricle. This is right ventricle, right atrium. And the circulation is this, that this is the left ventricle, blood comes in here, from here it goes to aorta. Keep an eye on a couple of valves over here. This is the atrioventricular valve on the left side, that is the mitral valve or bicuspid valve, right? Mitral or bicuspid valve. This is aortic valve, I'll write it here, aortic valve is here. Then on the right side, of course, pulmonary valve and the tricuspid valve, but we are not interested on the right side of the heart at this time. Aorta then takes the blood, it sends the blood over to the head and neck area, it then sends the blood out to the rest of the body as well. Then the blood comes back in the right atrium, from there to the right ventricle, from there it goes to the lungs, and from the lungs, this is important, from the right atrium the blood goes to the lungs, these are lungs, and then from the lungs oxygenated blood comes back to the left atrium. Why is this important? This part is important because when this heart is going to fail, it's going to create a back pressure that would cause accumulation of fluid in the lungs, and that is the majority of the clinical symptoms that you would hear from the patients. So that is why this is important to understand. So now let's see. What happens is blood pours in during the diastole, it fills, this is the papillary muscle, this is another papillary muscle holding on to the valves. Why did I make them? It is important to understand because their dysfunction will also be important. So the blood is filled. Then comes a systole. The blood now is going to be ejected. However, let's say that this heart unfortunately developed, this ventricle, left ventricle developed an ischemic problem. Why did we develop an ischemic problem? Maybe the person had an coronary heart disease, or maybe ischemic heart disease was because of long-standing hypertension, again causing the coronary heart disease, or there was diabetes mellitus, or there was atherosclerosis, high cholesterol, or the patient has, it is age related, and with the progressive age the arteries start becoming stiff. So the end result is that there is a ischemic heart disease. When this damaged heart, when this injured heart is trying to systole now, trying to contract now, it will not be able to generate enough force to move the blood or enough blood out in the aorta and to the body. That is the basic problem, that is a systolic dysfunction. Now, what things can cause this? What is the etiology? As I said, ischemic heart disease, post myocardial infarction. So myocardial infarction occurred. After that, that part of the muscle has become scarred and weak, and it bulges out, and it will not contribute in the contraction mechanism, and due to that the systole has become less efficient. Then what else can be there? Fibrosis of the heart. So if there is damage to the heart by viral reasons or by myopathies, and then there is fibrosis, the fibrosis would also cause the heart to be damaged. Dilated cardiac myopathies, most of those are idiopathic, some of those are congenital, others can be because of the chronic alcohol use or wet beriberi or viral like Coxsackie viruses, Chagas disease, doxorubicin medicine. All of those can actually cause dilated cardiomyopathy. in the dilated cardiomyopathy, the heart has become so much dilated and so large that it cannot go into a systole properly. So imagine it's a big bucket with a small amount of volume of blood in it, and you try to squeeze the bucket. So if you don't squeeze it all the way, the blood is not going to come out. So all of these are the problems with the systole. Now as the systole progresses, systolic dysfunction progresses, what will happen? Blood will start pooling. I'm going to make blue colored blood here. What is this blue colored blood? It's not deoxygenated. It is that extra blood that could not be ejected. So ejection fraction has reduced, cardiac output has reduced, contractility is reduced. That extra blood is now pooling in the ventricle. That blood pooling in the ventricle will mean then slowly blood would start pooling in the atria. By slowly I mean over days and weeks and months, the atria would start having the blood pooled, atria would start dilating under that pressure, there would be thrombi forming in the auricles or appendages of the atria. Then there is another thing, as the blood starts pooling now in the atria as well, there would be back pressure. The blood that has to come back from the lungs into the atria, that blood would have difficulty coming into the ventricle, into the left heart, because left heart is already congested, already filled. That would cause blood pressure in the pulmonary vessels to go up, and that would cause blood volume to go up in the pulmonary vessels. As the blood volume and pressure goes up, I'm going to make a pulmonary vessel here just to show you what does that mean. So artery brings in the blood. Let's make a capillary that is big enough here that we can see, and then the venule, right? Now we know that capillaries have gap junctions. There are cells in the capillaries, and then there are junctions between the capillaries through which the exchange of nutritional substances happen. As there is increased blood volume and pressure, what will happen is that the blood vessels would start becoming dilated and bigger under pressure. That would cause, so here is the important thing, oncotic pressure, which is the pressure of the fluid inside the vessel, oncotic pressure will increase. Hydrostatic pressure, why did I say oncotic? Hydrostatic pressure, which is the fluid pressure, oncotic is the protein pressure. Hydrostatic pressure inside the vessels would increase. That would cause blood or the fluids to start exuding from the junctions. It is like if you take a leaky pipe and there are puncture holes in the pipe and you increase the pressure on the pipe, those leaks would start jetting out. So this extra fluid that would come out will start accumulating in the lungs. Now how does that happen? This is important to understand. So I'm going to make an alveolus over here. Let's say this is an alveolus, and there is a capillary. I'm just going to make it red. You know that one end of the capillary is arterial and the other end is venous. So this is a capillary. Now what happens, as the blood pressure, as the blood starts pooling here, the pressure in the capillary goes up. That increased pressure would cause the exuding of the fluids out. So where will these fluids be going first? These will go in the interstitial tissue, interstitial spaces of the lung tissue. That means the person would start becoming breathless. Why? Why? Because interstitial spaces are participant in the respiratory membrane, and now inside the respiratory membrane we have increased fluids. So we have reduced the efficiency of the respiratory membrane. That means gaseous exchange will become compromised. That means the person would start experiencing breathlessness or dyspnea. In the beginning, the patient would not find dyspnea at rest. What would happen is when the patient is exerting, when he is doing activity, exercise, he'll become more breathless than normal. Then when he's speaking, slowly this would progress. So when he's speaking, he'll become breathless. And then there would be a time, if this whole cycle is not stopped, there'll be a time that even at rest the patient is breathless. Then there will be a time that when the patient would lie down, we'll talk about it, orthopnea would happen. So now, first of all, interstitial transudate is present, edema is present. That would cause pericapillary J receptors to become triggered. These receptors are connected with the vagus nerve or vagi. So when they get irritated, when you try to inspire fully, what happens is that this rubbing and irritation of the J receptors would trigger the vagi, and vagi will block the inspiration. So patient cannot take a full inspiration, full inhalation. Then what would happen? Fluid would enter the alveoli. Then when the fluid would enter the alveoli and there is alveolar edema that would develop, then the patient would start coughing, and because of this extra pressure here in the vessels, what would happen is even erythrocytes will come out. Erythrocytes come out for two reasons. One, under pressure, the gap junctions have opened up enough that the erythrocytes can squeeze out. Second, there are going to be vessels that are bursting, vessels that are breaking, that are rupturing under the pressure. So the result of that is that there is bleeding. So there is both bleeding and then innocent exudation of the RBCs. The end result is that the macrophages that are sitting here in the alveoli, alveolar macrophages, these guys are going to engulf and eat these RBCs. Hemoglobin in the RBC is going to now convert into hemosiderin. Now when the patient has cough and sputum, that sputum, number one, will look rusty in color, and number two, if you take that under the microscope, you'll see heart failure cells. What does that mean? These are the macrophages that have eaten up the RBCs and they have hemosiderin in them. So you can see that. Now the patient's breathlessness has increased. This is the congestion in the lung. That is why this heart failure is called congestive heart failure. If this continues, then what would happen is that the lungs, where do they get the blood from? Lungs get the blood from the right heart. So that pressure wave will now start affecting the right heart from ejecting into the lungs, because lungs are engorged and they are thick and they are heavy and they are edematous. And you're trying to pump more blood. It's like a sponge that is filled with the water and you're trying to pour more water on it. So now the right ventricle would start undergoing stress. That would start failing the right heart. So the most common cause of the right heart failure is the left heart failure, which is causing the back pressure. So this congestion in the lungs would occur, then the right heart would start failing. If that does fail, then the right heart failure would appear as well. That's a separate lecture, we've done it. So this is the systolic dysfunction, etiology and the clinical parts of it. Of course, what does that mean? That means, if you see clinically a little more, costophrenic angles will become blurred because of the fluid accumulation in there. If you look at that in the chest x-ray, you'll see that the costophrenic angles have gone. Then the infiltration would appear, alveolar infiltration would appear on the chest x-ray. Perihilar congestion and upper lobe congestions would appear in the chest x-ray. Perihilar congestion is sometimes called the bat wing appearance. So you'll see the bat wing appearance on the chest x-ray. When you put the stethoscope on the patient's lungs, on the patient's chest, you would hear what? You would hear rales. Why? Because there is fluid accumulated there. You will hear crackles and crepitations. What is that? Because of the fluid that is present, and when the patient inhales, there are bubbles and these bubbles are breaking, and that gives you the crackles and creps. So these are the sounds that you would be seeing. Now let's go to the second reason. So this was the reason where the contractility of the heart is reduced. We'll do the compensatory mechanism in a minute. Let's also now look at the compliance problem. Let's say that this ventricle is now less compliant. What does that mean? Compliant means the distensibility, elasticity of something. What we are saying is that somehow the ventricle has become less compliant. What does that mean? Maybe this ventricle is hypertrophied. Maybe this ventricle is hypertrophied. What do you think? What will cause it to become hypertrophied? What will result in this thing to become hypertrophied? Increased pressure of work. That means increased afterload. How will that happen? How will that happen? Increased hypertension. Essential hypertension can cause reduced compliance over time, and heart will become hypertrophied. Now, what kind of hypertrophy? Concentric or eccentric? So let's talk about that very quickly. What does concentric hypertrophy mean? Concentric hypertrophy means if this was a normal heart, ventricle, what happens is that the cardiac myocytes, so let's say this is a cardiac myocyte, another cardiac myocyte, a few cardiac myocytes, they increase in diameter, they become thick, their diameter increases. So number of sarcomere are fine, but the diameter of the myocytes increases and the heart becomes thick. Now this thickening of the heart means it is growing inward. So what will happen to the chamber, the cavity of the heart? Cavity of the heart will start becoming narrowed. That is dangerous. See where we are going? We are going towards diastolic dysfunction. So now the thickening of the muscle is eradicating the cavity. That would create this diastolic dysfunction problem where there is not enough blood to eject. So come back here for a second. So now the muscle is, myocytes are thick. This is called concentric hypertrophy. There is another situation where the heart becomes elongated. It becomes elongated. Why? Because there is more overload. So how do you separate them? Keep this in mind, please. Whenever ventricle is working against pressure, it will become thick, and that thickening is the concentric hypertrophy. Whenever it is working with more volume, that would cause it to be lengthened or increased in size, and that is called eccentric hypertrophy. In the eccentric hypertrophy, the myocytes increase, the sarcomeres, the number of sarcomeres in a myocyte increase in series, and so the length of the muscle cell increases. Number of sarcomeres in a myocyte in series increase, and that causes the increased length. And why is this increased length? This is really to accommodate higher volume of blood, and this is called eccentric hypertrophy. This is concentric hypertrophy. In both cases, there can be dysfunction. Just remember this, with the dilation of the heart, you can receive more blood. Diastole may be okay, systole may be problem, because now the heart cannot eject enough fraction of the blood. With the thickening of the heart, the diastole is now compromised. You cannot fill it properly. There is no cavity there, and ejection is fine. This is a force. This is a bodybuilder heart. It can do a lot. It can exert a lot of force, but there is nothing to throw out. So that is a diastolic dysfunction. So now let's see, what is a diastolic dysfunction? What causes this hypertrophy? Look, guys, think about it. You increase the afterload hypertension, that would cause hypertrophy. You cause the aortic stenosis, that would cause the hypertrophy, because now heart is pumping against the stenosed valve. There is one situation, don't forget this one. There is one situation where even after the hypertension or even after the aortic stenosis, the patient still does not develop hypertrophy. Do you know how? If there is a AV valve, that is a bicuspid or tricuspid valve, stenosis, then there is not enough blood coming in, which heart has to work with. So it is not dilating, it is not hypertrophying enough because there is not enough load, preload on it. So that is one condition where the bicuspid stenosis can help. Anyways, back here, hypertension, aortic stenosis, other problems for eccentric where we dilate. So hypertension and stenosis where we make it thick. Eccentric, restrictive myopathies, restrictive cardio, like Loeffler syndrome. The myopathies, for example, accumulation of glycogen and amyloid in the cardiac tissue. So glycogen and amyloid would come and accumulate and kind of make it useless, and the heart would start becoming dilated because it's really not a nicely functioning tissue anymore. The muscle has glycogen and amyloid deposited in it. Aortic and mitral regurg. So remember this, stenosis can cause concentric hypertrophy. Regurg can cause dilatation. Why? Think about it. When the ventricle squeezed and threw the blood out in aorta, if the aortic valve is not competent, then during the diastole, blood has to come in from the atria. It will also come in from the aorta. So volume of the blood will increase. So now instead of becoming thick, this heart will become dilated. It will become elongated and dilated. Right? So that would cause dilatation, and that will be called eccentric hypertrophy. Okay, so we understand the type of abuse that would cause it. Systolic dysfunction, remember ischemic heart disease, coronary heart disease, infarction, dilated cardiomyopathies. Diastolic dysfunction, remember concentric and eccentric. So in the eccentric, you have dilated heart, which may be causing systolic dysfunction as well. Concentric is the hypertension and the stenosis of the aortic valve. Eccentric is anything that can increase the volume here. That would be regurg on both sides, aortic or mitral regurg. Why would mitral regurg increase the volume? Here is why. When the heart goes in systole, the blood goes back into the atria. When the heart starts relaxing, that more blood now starts falling into the ventricle again. Then restrictive cardiomyopathies. Restrictive cardiomyopathies cause damage to the muscle tissue, like accumulation of amyloids or glycogens. Okay, now let's talk about the findings. We talked about it in a few minutes back as well. What would you find in the chest X-ray? You'll find Curly's lines. These are the edemas in the septal lines. Then you'll see the alveolar infiltrations. You'll see the perihilar congestion, upper lobe congestion, bat wing appearance. So that is what you'll see you'll see heart failure cells. Clinical, what are the things that you would see? The first thing I really want to clarify, cyanosis. Many students have said to me that, hey, cyanosis happens because the issue is with the lungs. But that is not the reason. Yes, there is an issue with the lungs, and that can exacerbate the cyanosis. But there's a different problem. Look, as the blood output, the cardiac output is low, blood is slowly flowing through the system. It's not flowing fast. Due to that reduced velocity, the tissues that are sitting on the side of the blood vessels, these tissues are going to extract more and more oxygen, because they have more time to extract the oxygen. So the tissues downstream, so for example, if the blood is moving from here, a small chunk of blood from here goes to my fingers, as it is passing slowly, the tissues are going to keep pulling the blood away, oxygen away. So when the blood reaches the fingers or the hand, do you think it has enough oxygen saturation to oxygenate them? No, so this area would become cyanosed. So cyanosis is not because a problem with the lungs, it is a problem with the slow movement of the blood. Pulmonary edema, we talked about it. Orthopnea and PND, this is really important to understand. So orthopnea is very simple. When the patient lies down, patient becomes breathless. Now what is the reason for that? What is the reason that when the patient lies down, so if I make a lying down patient here, this is a patient who is lying down. Why does this patient now get the breathlessness? Here is why. There are two mechanisms that cause this. One is that there is increased venous return. Increased venous return would try to increase the blood to be pumped from the heart, and because the left heart is failed, that blood would pool in the lungs, and that pooling, extra pooling, will cause breathlessness. That is one. This is called orthopnea. It is because of the redistribution of the blood. Second is paroxysmal nocturnal dyspnea. What does that mean? That means occasional attacks of nocturnal at night dyspnea, breathing. Patients actually wakes up as if he's going to choke and suffocate and die, and he needs to then have pillows to prop himself to improve his breathing. That is why it is also called pillow orthopnea, and we actually have a grading system with the pillows to say, is it one pillow orthopnea or two pillow orthopnea or three or four and so on. Now why does this happen? Look, if the left heart has caused right heart failure, that has caused edema in the dependent areas, then there is two problems. There are going to be two contributing factors. One is the redistribution of the blood as the patient becomes horizontal. Second is that as the patient is horizontal, this is for the PND, the edema in the tissues, this tissue, the fluid in the tissue will start becoming reabsorbed. It would take some time. It would take 1 hour, 2 hours for enough fluids to be reabsorbed from the interstitial tissue back in the vascular system and increase the venous return enough and cause accumulation in the lungs enough to cause suffocation or choking feeling. So patient started sleeping okay, but then the reabsorption occurred and redistribution occurred, and a few hours later patient woke up because there is accumulation of blood in the lungs. So please do not forget that. Of course, rales, crackles, we talked about it, bloody sputum, mitral regurg, yeah, so this is important, regurg and S3 sounds. This is why I made these papillary muscles. Now what happens is, look guys, the papillary muscles are holding the valves of the bicuspid AV valve, right? They're holding the leaflets of the valves. So let me say, these are the two leaflets, atria is here, ventricle is here. Now let's take one leaflet, and here is a papillary muscle that is pulling the leaflet down. So when the ventricle is contracting, it would push the blood up, and as the valve starts going back towards the atria, the papillary muscle is going to pull it down enough that two valves would come and close. And what is pulling them down? Papillary muscles. Now when the heart becomes hypertrophied or dilated, these papillary muscles are going to become displaced. So one was pulling this way and the other one was pulling at this angle. Let's say these are the papillary muscles. Now one of them is here. So when the valve starts closing, one closed here and the other closed here. There is a gap between the valves now. That gap is going to cause regurg. So regurg, mitral regurg, can actually be a consequence of the left ventricular failure because of displacement of the papillary muscle. So let's say this muscle has become displaced there now. So it is going to stop this valve here, while the other one is going to let the valve go up to this level, and so you will have a gap between them. That gap would allow the blood to go back to the atria. That would cause, number one, atrial regurg, so you'll hear a murmur. Secondly, look, because of this dilated heart and more blood volume, that is a problem. The problem is venous return is more and ejection is less, so there is more blood that is here. When the diastole would start and the AV valve opens up and the blood falls in that extra pooling of the blood, in extra bigger swimming pool of the blood, you throw more blood, that would create vibrations. That is S3 heart sound. Early diastolic S3 heart sound is related to the early signs of congestive heart failure, left heart failure. Now, late diastolic sound S4 can also be present, but S3 or S3 gallop is the most important thing that is present in this situation. Okay, so we've talked about the X-ray congestions, perihilar congestions. Yes, let's also talk about ANP and BNP. Atrial natriuretic peptide and brain natriuretic peptide. So I'll talk about that in the context of the compensation mechanism. When the heart starts failing, when the cardiac output reduces, there are few compensation mechanisms that start coming into play. Let's talk about ANP and BNP first, and you can then skip the others if you already know them. ANP and BNP is really part of neurohormonal compensation mechanism, in which as the cardiac output reduces, sympathetic system becomes triggered within 30 seconds to 1 minute, and that brings in norepinephrine, that causes vasoconstriction, that also causes increased heart contraction, and the force of contraction is increased, conduction velocity is increased, and the heart rate is increased. We've talked about that in the separate lecture. That increased force of contraction would try to increase the cardiac output. So sympathetic system would try to increase the venous return and the cardiac output. Renal angiotensin system would become engaged a few days later, and as the renal perfusion is low, and then it would try to bring it up. Again, we have a separate lecture about the compensation mechanism and management of the cardiac failure. I'm just reviewing that here. So that would also increase the blood volume. That increased blood volume has good and bad. In the beginning it is good. Increased blood volume will mean increased venous return, will mean increased cardiac output. Good, good. Increased blood volume would also distend the veins, and that would allow the blood to flow easily through the veins. So initially the blood volume increment is a good thing. It's a good compensatory mechanism. However, as you keep increasing the blood volume, if the cycle does not break, then blood volume will be so much that it would cause damage. Then is the atrial natriuretic and brain natriuretic peptide. So first, students ask me all the time, why the ANP from atria but not VNP from ventricles instead of BNP? So look, there were some other than human creatures, procrine creatures, in which whose brain had this hormone, and it was found there first. That is why it was called brain natriuretic peptide, and then it was found to be released from the ventricles as well, stretched ventricles. So now what happens is both ANP and BNP, they are released from the atria, ANP, and BNP released from the ventricle when they are stretched. So tell me this, if you are ventricle and you release BNP when you're stretched, what do you want? What is your problem? You don't want stretch, that is why you did it, right? So that means you don't want extra volume of blood. That means you're telling the body to reduce the blood volume. How can you reduce the blood volume? How can body help you? Vasodilatation, that is one, and then more of the sodium and water excretion. So it would help kidneys and the vascular system to reduce the blood volume or reduce the venous return. So that is the function of ANP and BNP. Although in the left heart failure, BNP is a good marker, an indicator that there is heart failure or not. So let's say if you see pulmonary edema in a patient and you want to rule out if there is a heart failure associated, you can check for the BNP, and it would help you rule in or rule out the heart failure. It is also an index of survivability of the patient as well. So that is the ANP and BNP. Other quick mechanisms for the compensation. One mechanism you are very much aware of, we've talked about it, Frank-Starling mechanism. That has what happens as the contractility goes down, the Frank-Starling mechanism there'll be more venous return, right, and less ejection. That is the problem we're talking about. So when there is more blood left in the heart, that would stretch the heart more, Frank-Starling mechanism would engage and would squeeze the heart more. So that would increase the contractility. In the early days, it is good. It is called compensation. And if the cardiac output starts going back towards normal, we'll say compensated cardiac failure. However, if let's say the heart is damaged enough that even after the increased contractility through the Frank-Starling mechanism, increased calcium present there, it still is not able to contract good enough cardiac output, then the venous return would just continue to increase and the blood would just continue to pool, and then we'll say that this is a decompensated cardiac failure. So decompensated cardiac failure is simply where the compensation mechanisms have failed to bring the cardiac output back. Compensation was happening. Then is the remodeling. Remodeling is, we just talked about it in detail, eccentric and concentric hypertrophies can happen, the cardiac tissue can reshape its structure. So any change in the shape, size or length of the cardiac tissue is the remodeling. Remodeling can be physiological, where let's say you just decided to become an athlete today and you started running and doing exercises, your heart would start becoming remodeled, it would start becoming thick and better, and that is okay. But in pathological conditions, these hypertrophies, as you saw, either the eccentric or concentric hypertrophy, this remodeling is actually going to create even more of a problem. You know, the biggest problem in this case is, other than the ejection fraction problems and cardiac output, other is that once the heart becomes thick because of the cardiac output issues or failure, its own oxygen demand goes high. So now heart wants more oxygen while it is failed. So how would it give more oxygen? It is not giving oxygen to others and also not to itself. So that would just put heart in a vicious cycle of continuous damage. So either you come in as a doctor and fix this, or patient unfortunately would die. So this is the left ventricular failure.